Chapter 26 talks about narcotics, narcotic antagonists, anti-migraines, and begins with a discussion of pain. Back in Chapter 1, we had a discussion of controlled substances, and then the DEA controlled substance list is found on page 12. So you can look back at that just as a referral that most narcotics fall under the Class 2 controlled substance list. Narcotics act at the specific opioid receptor site, and they can cause analgesia, sedation, or euphoria. They can cause central nervous system. Their side effects are typically sedation and particularly respiratory depression. These drugs can also cause orthostatic hypotension and GI effects of constipation. So typically patients who are on narcotics after surgery need to increase their fiber, increase their water intake, get moving as quickly as possible, and may require the use of a laxative, and we'll talk about laxatives at the end of the semester. Narcotics have anticholinergic effects of nausea and vomiting, pupil constriction, urinary retention, as we've talked about earlier, and narcotics used over time raise the risk of the patient developing a dependence. Narcotics are delivered in different ways. They can be given orally, they can be given IV, IM, they can be given by transdermal patch. So when the dose is adjusted from IV, which requires a lower dose of narcotic because it rapidly enters the bloodstream and is effective to be used by the body, when you move to an oral drug, that drug has to pass through the liver. So only 50% is absorbed if given PO, so you will need to give a larger dose orally than you would in the IV. And there are charts that help those help providers to make those conversions so that patients maintain the same amount of pain relief regardless of the method of administration. The chart gives you a list of narcotics that are used, and they all will have the same side effects of sedation and respiratory depression, but they sometimes have a little bit different use. So codeine is typically given orally, and it is given typically as part of an antitussive cough syrup because of its effectiveness in decreasing the cough reflex. And you typically for codeine need to be very cautious if the patient is also taking an MAO inhibitor. Fentanyl is a very powerful narcotic that is used typically in surgery. It can be given with a transdermal patch for chronic pain and used to control breakthrough pain. Because of its long half-life, the respiratory depressive effects may last longer than other narcotics. It is being very much abused in the nation these days and can be spiked with heroin to give a quick high, and patients who take fentanyl illegally often have severe respiratory depression and adverse outcomes. Hydromorphone is used for severe to moderate pain, as is meperidine. Morphine, my caution here is do not confuse morphine with hydromorphone. Morphine is a different medication than hydromorphone, and it's typically given orally. IV, IM can be given by patch, can be given in an extended release form, and if given too rapidly can cause something called speed shock, which really drops the blood pressure. So you give it over a period of about 5 minutes. The oral drugs on your chart include oxycodone or OxyContin and Percocet, or the brand name of Tylox. These drugs are also class 2 and have more restrictions with use and sale than some of the things like codeine, which is a class 3. You can't crush or chew any of these extended release drugs, regardless of which drug you're putting in that extended release. They can't be cut or crushed because it would rapidly release the medication instead of slowly releasing over time. The reason that I added Percocet to the list is because It is a combination drug that includes the narcotic and either 325 or 650 milligrams of acetaminophen. So when we talked about acetaminophen, we talked about the fact that you have to monitor that 24-hour intake, and so therefore any narcotic that has acetaminophen as part of its components needs to have that amount of acetaminophen subtracted from the 4,000 milligrams per day. Other narcotic agonist antagonists that are used particularly to relieve pain in labor and delivery are butorphanol and nalbuphine. These drugs have the same adverse effects as other narcotics, and they may produce psychotic-like symptoms. Again, as with all narcotics, you can, with long-term use, develop a withdrawal syndrome, and you were provided those side effects and symptoms earlier in another chart. So these are butorphanol and nalbuphine are typically used to relieve pain in labor and delivery. For all narcotics, there is one antidote, and the antagonist or antidote for a narcotic is naloxone. It strongly binds to the opioid receptors to reverse opioid overdose effects, typically that respiratory depression. The problem that you can have is an acute narcotic abstinence syndrome, which means that the patient who's received naloxone, if you give a high enough dose of the naloxone that completely knocks out that narcotic, the patient can have severe pain. They can have central nervous system excitement, raised blood pressure, raised heart rate. The drug is given for suspected overdoses. Anytime the patient's respirations get below 8, in the hospital setting, you typically have an order for naloxone. It can be used in the public domain. It's usually given in an auto injector in the thigh, and it can be repeated. All patients who receive naloxone need to have medical treatment. The concern for all providers or all individuals who give naloxone, including you as the nursing student, you need to know that the half-life is less than that of the opioid. So you may give the naloxone, the respiratory rate comes back up to 20, the patient seems to be doing well, and then suddenly the respiratory rate drops again. And that's because the naloxone has worn off, but the opioid is still in their system. So patients need to be monitored carefully, and that dose may need to be repeated. The anti-migraine agents are used to treat migraine headaches. Common migraines occur without an aura. They cause severe unilateral and pulsating pain that can be accompanied by nausea and vomiting and sensitivity to light and sound. The drug that we chose as the exemplar in this section is sumatriptan, and it is used to treat acute migraines and cluster headaches. It is not a preventative. It only treats the condition once it has occurred. Patients may experience some numbness, tingling, and burning, or sensations of coldness or just a strange feeling after taking sumatriptan. This drug does have fewer vascular and GI effects than some of the other ergo derivatives. And sometimes you may need to switch to a different triptan to get an effective drug. Because they're a newer class of drug that patients may respond better to those than to others, and you need to avoid giving them with an MAOI inhibitor, and so because it can increase vasoconstrictive effects and cause hypertension. So you need to take the patient off of the MAOI inhibitor 14 days before starting use of a drug like sumatriptan. Chapter 27 talks about general anesthetic. There is a review of general anesthesia and the stages of general anesthesia. So that, and then there is a discussion of spinal anesthesia. The stages of general anesthesia include a loss of sensation. Stage 2, the patient may have some combative excitement, And stage 3, they start relaxing, they lose their reflexes, their pupils dilate. And in stage 4, this is total anesthesia with a severe central nervous system depression. Balanced anesthesia uses a combination of medications during general anesthesia to help prevent some of the adverse effects and side effects of receiving the anesthesia. Preoperatively, patients may receive an anticholinergic such as atropine to decrease their sensation. So that decreases the saliva and makes it easier to intubate the patient and maintain their airway. The sedatives or hypnotics may be given to relax them, to facilitate some amnesia, to decrease that fight or flight sympathetic stimulation in the central nervous system. An antiemetic may be given during general anesthesia to decrease the nausea and vomiting that occurs because of the slowing of GI activity. And that helps the patient as they're waking up to experience less nausea and vomiting. An antihistamine may be given to decrease the risk of an allergic reaction, and to help them to dry secretions. And narcotics, again, are given for analgesia and sedation. So understanding that balanced anesthesia is given to the patients to help manage those symptoms is very important concept for you to understand. The midazolam that we've talked about before is used for short-term sedation in procedures such as colonoscopies, and can cause some post-operative amnesia, so you don't remember what happened when you were in the procedure. Respiratory adverse effects include apnea and laryngospasm, and respiratory depression, cardiac arrest, and phlebitis at the IV site. Because it has a very long half-life, patients are cautioned against driving for 24 hours or making legal decisions for 24 hours after they receive midazolam. The local anesthetic that we have discussed is lidocaine, which is used for infiltration anesthesia. So if you're having stitches placed because of a cut, they may use lidocaine to numb that site. Sometimes they will use lidocaine to numb prior to inserting an IV line. Patients tend to have headaches if they're going to have adverse effects, or with a large amount of lidocaine, they may develop some hypotension. Common side effects of receiving lidocaine include burning and stinging at the site. Respirations, heart rate, blood pressure need to be monitored, as well as the IV site needs to be monitored. Chapter 28 discusses neuromuscular blocking agents. Pancuronium and cistracurium are used to block and cause paralysis. And you need to know that with all of this class of drugs, whether they are regular or depolarizing neuromuscular blocking agents, such as acetylcholine, none of these cause sedation. They only cause paralysis. It is extremely important to sedate the patient prior to them receiving one of these neuromuscular junction blockers or a depolarizing neuromuscular junction blocker, because no sedation occurs with this class of medications. Succinylcholine is very short-acting. It's usually used for intubation, while the pancuronium and cistracurium can be used for patients who are being mechanically ventilated. Malignant hyperthermia is a problem for all of these drugs, so please look at the chart and the discussion of malignant hyperthermia that is found in your textbook.